you guys just watched the video with Sarah RN, explaining the important parts of a medication label. So, there's always going to be on the label the name of the pharmacy, the prescriber's name, that is going to be the doctor's name, the date the medication was filled, the prescription number. The prescription number is a lot of times what you're going to need when you're calling in refills. So on the medication communication, you can write on there the prescription number, the patient's name, the patient's date of birth, the order or directions, the medication's name, strength, dosage, and form, quantities, refills, and axillary labels. So axillary labels are side effect labels. These are very important for you to be aware of when you're handing out a medication, um, especially in our elderly who are already at an extreme fall risk. A lot of these medications do cause dizziness, vertigo, other things that could contribute to falls. So please make sure that you understand what you're giving and why you're giving it. Other very important axillary labels that you might have on a bottle or on a bubble pack, such as, don't drink with alcohol beverages. We do unfortunately get residents who struggle with consumption of alcohol. And so it is very important, regardless of the Del Monte location, whether it's a drug free, alcohol free location, or if it is a location that does allow the residents to partake in happy hour and stuff. It is really important that if you're at one of the locations that does partake in happy hour weekly, that you educate your resident on, the medication that they're receiving does not mix well with alcohol. And so that resident should either A, not partake in happy hour, or B, limit their use. And it's also very important that you communicate this with the physician, that the resident does, like to partake in happy hour. Other things such as do not crush or chew medications. We might not realize how fragile these medications are as far as the makeup components of them. But a lot of times, just simply crushing a medication will change the compound within that medication, and that medication, it might not have the same effectiveness, or it might interact with other medications differently. So it's really important that we follow that direction very closely. And the same with like taken with food, taken with water. Some of the foods will upset the stomach, some foods will make them more dehydrated. So make sure you're paying attention to these labels. All right, so this is a point in time where you're going to pause the video and we're going to quiz you on what you have learned so far. Don't worry, this is just a quiz. It's not going to make or break you in your medtech training at this point in time. It's just to make sure that you've absorbed what you have learned, and that you are understanding what you're learning. And maybe we need to go back and retouch something if you're not, obtaining the information very well. But here's another important thing I'm going to tell you right now, is a key phrase that we're going to ask you to make sure you are truly watching this video, if you're watching this video on your own time. And that key phrase is butterflies. So butterflies are our keyword, key phrase to make sure you've watched this video. All right. quiz is done, pins are down, our minds are focused, and we are ready to move on. So, common medication errors. Um, Unfortunately, we're human and errors are going to happen. Our goal is to be 100% error free, but however, if an error occurs, we want to make sure that you know how to properly handle an error and how to effectively communicate said error. So, most common errors include never give medication with a written order only. Here's why. The doctor might have said one thing, and because you don't have true nursing training, and what I mean by that is you've gone to school for 18 months to 4 years and gotten your LVN, your RN, that you don't have all that knowledge and background to you to take a verbal order, and sometimes verbal orders are said differently than how they are written. So when a physician calls in with a medication change, no matter what type of medication change it is, whether it be holding an order, changing the frequency of an order, changing the dosage amount, never ever go ahead and act upon a verbal order without receiving that written order first. So, what you're going to say is, thank you, doctor, very much for calling this into us. But however, the policy of Del Monte is because, I am medtech trained only. I'm not a licensed clinical vocational nurse or a registered nurse. I cannot accept a verbal phone order. Can you please fax that into our med tech room? So doctors are going to understand that, and they're going to respect your honesty, because at the end of the day, they don't want to be held liable either for giving a written or verbal order to somebody that really should receive a written order. So you also must wait for that order to come in. If it's not came in within 30 minutes, pick up that phone, call that physician, let the physician know. Also, while you're waiting for this, document in a progress note, Mrs. Smith's primary care physician, Dr. Jones, called in with a order change of once per day Xanax to 3 times per day Xanax, waiting for written order. So that way the verbal communication is documented, but it's also documented the medication is not going to be given in until verbal order is received. Once verbal order is received, then you can go back and through your progress notes, written order received, C medication order or CMAR or whatever. Okay, but we got to wait for that order. Wrong medication, especially with those that have names that sound alike. There are a lot of medications, including a lot of medical diagnoses that sound alike. So this is the other reason why we must wait for that written order. Wrong resident. You didn't use an ID on the MAR. You didn't check a bracelet. You didn't ask them for their name, their date of birth, their room number. You didn't do any identifying information. This does happen. And so that's why it's very important, if we are working in our memory care, we look at the picture on the medication record to ensure we have the right resident, because sometimes our residents don't give us the right names. Funny story, when I first started working for Del Monte, sweet little lady in one of our memory cares kept telling me her name was Ruby. And I believed her name was Ruby. And I kept saying Ruby this and Ruby that. And unfortunately, that was not her name. So it's very important that you guys do your due diligence and you check the picture against the MAR. Now, once you've been there a while, obviously you're going to know your residents and who they are, but it's still good to check that MAR. Wrong time, wrong route, wrong dosage, that also happens. This is part of your triple check. That's why, when you get a new medication, you're going to pull the MAR out, you're going to pull the label, and you're going to pull the order, and you're going to make sure all three match. At the beginning of the month, when we get a new MAR and the new orders come in, we're going to perform this triple check. At any point in time, if a medication doesn't look right in the bubble pack or in the bottle, we're going to pull out the MAR, the order, and the bubble pack or the bottle, and we're going to perform a triple check. Okay. Wrong preparation. Once again, it's all about how we prep that medication. So if we don't read the order or check the axillary notes and we go rogue and we crush a medication that is intended to be swallowed whole, this could cause an unfortunate side effect. So please make sure that we are doing that. Unavailable medication, a refill not completed. So we didn't report into our supervisor that a medication ran out. We didn't do our due diligence to make sure that medication came in. And now Mrs. Smith has been 4 days without her medication. Many of our residents are very fragile in the sense that they have medical issues that can result in death without their medications, blood pressure medications, blood clotting agents, such as Plavix and stuff, could have life-threatening consequences. So please make sure you are reporting medications that are out within 2 days or medications that are refused within 2 days. Errors of omission, meaning there is a medication technician provides medication services and resident care environment, but it just happens. So we just got to be very careful when we're doing our meds to make sure we're following all the orders. Failure to shake a medication. There are medications such as liquid antibiotics, such as inhalers, that if we don't mix them right, it could have consequences. Mixing, rolling, creating air bubbles, such as in insulins. So in our insulin pens, we're going to, do a click or two before we redial it in to make sure we remove air bubbles, all that fun stuff. Incorrect amounts of insulin given or incorrect amounts of fluid given with a medication. Given medications before a meal instead of with the meal or after a meal, and then failure to administer MDIs in the correct order. So meter dosed inhalers. There are inhalers that are albuterols, Xopanexes that really shouldn't, that should be given in a certain order, such as the meter dosed inhalers that are for the steroids. So make sure you follow all those directions correctly. This is where our triple check comes in. When we're doing the triple check, we're looking at the expiration dates on the bubble pack and or the bottle. Given a medication outside the expiration date, medications change dramatically as time goes on, and this can affect their effectiveness. Never administer a medication beyond the stop date. So, for example, Mrs. Smith might have been going in for a procedure, and maybe before her procedure, they ordered a certain type of what's the word I'm looking for? Preventative infection control. So maybe like an antibiotic, and it might have been a lower dose of type of an antibiotic, and then she had the procedure done, and now she is having a antibiotic post surgical event, and it might be a stronger antibiotic or a different type of antibiotic. And if we didn't stop the order of the pre-surgical medication and we're still giving that one on top of the post, now she could be receiving too much of antibiotic that could cause some medication issues. So it's really important that when a medication says to stop on this date, that we stop it on this date. Another thing, medications, if they have a new change in color, if their consistency, so some of our liquid medications, if all of a sudden they turn more thicker or thinner than what they had been, or if they've got a new odor to them that they hadn't had before, don't give that medication. Contact the pharmacy, contact the doctor, and document. Administer only medications taken from properly labeled containers. So if the container that the medication comes in maybe doesn't look right, maybe there's a label on top of a label that wasn't communicated from another med tech that, hey, we had to relabel this medication because the label was wrong, or maybe the box that the medication came in looked like it had been opened prior to you guys getting it for the first time for first administration. Please be mindful of those. Never pre-pour medications. Only pour before giving. So a lot of our locations, they love to pre-pour. And the problem with pre-pouring is, I know that Jenny is going to be short-staffed on the PM shift. And so I'm going to help Jenny, and I'm going to put all of my residents' medications in these little tiny bubble cups, thinking that I'm doing something wonderful to help her out. The problem with that is that's when medication errors can occur. Lids with the resident's name written on a label could be mixed up, or I could, not intentionally leave a medication out or give too much medication in a pre-pour. And now Jenny's coming in. Jenny is handing over that medication to Mrs. Smith, and Mrs. Smith takes that medication and it's the wrong medication and it has dire consequences. Unfortunately, it's not going to be on me. It's going to be on Jenny. It's going to be on Jenny because Jenny's the one who handed that medication. Jenny's the one who signed off that she opened and reviewed and made sure that medication was correct. In reality, Jenny didn't pour that medication. Jenny didn't prep that medication, but Jenny signed off that she did do so. So please bear in mind that pre-pouring is not okay, and that's when we're going to have a larger amount of medication errors. Never give medications without a written order, and this includes over-the-counter medications. So Mrs. Smith's daughter comes in. Oh, my mom's been having a headache. Here's some Tylenol. And we feel for Mrs. Smith. Mrs. Smith does have frequent headaches. But however, without us being pharmacy trained, we don't know. There might be medications that over-the-counter medications such as Tylenol could have a severe interaction with. So never, ever give a medication without a written order, and this includes over-the-counter medications. Never borrow from another resident's medication. It is never okay to borrow some Lancets or some test strips from Mrs. Jones to give to Mrs. Smith. It's never okay to say, well, Mrs. Smith, I know, takes the exact same frequency and dosage of Xanax, and Mrs. Jones has some. So it's never okay to swap them out like that. Not only now have you potentially given medication that could be slightly different and you not know it to Mrs. Smith, but now Mrs. Jones is going to be short on her medication. So you're not really fixing the situation, you're creating a bigger situation. So never ever borrow or swap out medications with other residents. Always remain with the resident until all the medication is completely taken. So I've seen this like 100 times where the nurse will come in or the med tech will come in and Mrs. Smith is in the middle of her lunch. And so she's going to sit the medication on Mrs. Smith's lunch tray. Miss Smith says, okay, I'll take my medication when I'm done eating. And the med tech walks out the room. Mrs. Smith forgets about the pills. The caregiver comes in and takes the tray away. And now Mrs. Smith has missed her lunchtime medications. So you got to make sure you physically watch Mrs. Smith take her medications. Never keep stock meds for just in case. So if there's, excessive amount of medication built up because maybe Mrs. Smith has refused a bunch of medications, we're not going to keep anything more than the recommended overflow for our med room. So we shouldn't see like 2 or 3 months worth of a medication in there for Mrs. Smith unless it comes from the pharmacy that way. Prepare medications one at a time. This goes back to the pre-pouring scenario that I was telling you guys about. We are only supposed to, as you guys recall from that video, do one resident's medications at a time. So if we're pre-pouring, chances are we got 4 or 5, 10, 20 medication little cups opened up at the time, and we're prepping them. And that's how medication errors happen. Give the medication to the individual as soon as you prepare it. Once again, back to pre-pouring, right? Someone could come in, and I would hope that nobody here at Del Monte would do this, right? But we pre-pour our medications, and I'm feeling a little pissed off at the oncoming med tech, and I'm gonna change some cups around with the caps, and so now the meds are all messed up. You just don't know, you guys. When we do a pre-pour, there's so many different things that could happen once we poured it. It's just not worth the risk at the end of the day. I would rather do a report that a medication was given an hour too late or an hour too soon than to give a report that a medication error happened and it resulted in an injury or a death of a resident. I cannot stress that enough. It's just not worth it, you guys. Document immediately whether a medication was refused, augmented, and why. And so I recommend, you take a couple of the refused medication reports and the medication communication sheets with you guys. So that way, if something is happening, you can write the name on it and briefly fill out some of the key components. So when you get back to the med room, you can finish it and send it off to the appropriate physicians and pharmacies and so forth. And never talk to others or ask them to talk to you when they're in the middle of a med pass. It's really important that when you're doing something so critical that your focus is only on this medication administration. And it's really important for us to support that med tech during that time frame. Administer medications when there is a documented allergy. So, for example, Mrs. Smith went to see a new neurologist, and the new neurologist maybe didn't realize that Mrs. Smith has an allergy to Xanax or Ativan. And Mrs. Smith comes back with an order for said Ativan. And Mrs. Smith's daughter decided to be helpful and stop off at a pharmacy and pick this up on the way in and not go through our Del Monte pharmacy. And so we get this new order for the medication, and we go, but wait a minute, Mrs. Smith does have a documented reaction to Xanax. What should the med tech do? I hope you're all saying do not give the medication. We don't give the medication. We immediately call that provider. We call that pharmacy. We document that we are holding said medication and the reasons why. And we make sure we put this into the communication log and we pass this all along to the next med tech coming on. And we also mark the bottle so that way it's not accidentally given by somebody else. If you use discounted or expired or contaminant medications, so if we know a medication was left outside of the refrigerator, we shouldn't be giving it, you guys. If we know that it was accidentally mixed with something else, we shouldn't be giving it. Always review vitals and trends prior to giving a high-risk medication. No, you should inform your director of nurses or your administrator or your clinical liaison if there's any changes in vitals, such as the glucose levels are really high, blood pressure is really high. You should also be informing the physicians as well so they can make adjustments either to the medication, but not with a verbal order. They must send you a written order. Or if they're going to make a decision to send Mrs. Smith out to the hospital. Interruptions. Once again, I'm picking up the phone. I'm interrupted. Medication error. Medication administrations that lead to med errors. There are refills that are not being done. Borrowing from other residents. A lot of this is repetitive, and it's repetitive for a reason. I'm bringing this up yet again 2 minutes later because it happens, and it happens frequently. All right, so we're going to go into a video on how to take vitals. Bear in mind that we are to assist our residents with vital taking. We are to never actually perform the vitals ourselves, but we can assist our residents in vitals. So here is the video, and here is the next video, or not video, but key phrase. Our key phrase is going to be the delta. Next key phrase is going to be the delta.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and today I want to demonstrate how to take vital signs. First, what you want to do is you want to gather your supplies. Typically what you're going to need is a stethoscope with a blood pressure cuff, along with a thermometer of some type, a pulse ox, a watch, and some gloves, along with a disinfectant wipe to clean the items that are not disposable. Then what you want to do is you want to perform hand hygiene and don the appropriate PPE if necessary. Like if your patient's in contact precautions, you'll want to put on the correct PPE. Now, what is collected during the vital sign measurement? Well, you'll be checking the patient's blood pressure, heart rate, respirations, and temperature. In addition, you'll be asking the patient their pain rating, which is sometimes referred to as the fifth vital sign, along with collecting their oxygen saturation. So I've arrived to the patient's exam room and I've performed hand hygiene. Now what I want to do is I want to introduce myself to the patient and tell them what we're going to be doing. So hello, my name is Sarah. I'm a nurse here and I want to be taking your vital signs. Is that okay with you?
Yes.
Okay, then you want to do your patient identifiers by looking at their armband, having them tell you their name and their date of birth. Then I like to start with the easiest thing, which is pain. And so I'm going to ask him his pain level. Now this is a very easy and important assessment tool because High pain ratings, if the patient is in pain, it can alter their vital signs. It can increase their heart rate, their blood pressure, and respirations. And it's really important, especially to ask a patient their pain level if they've just had surgery or some type of trauma. So to assess pain levels, you can do that with various scales. Most commonly, we use the 0 to 10 numerical scale. So can you tell me your pain, with 0 being no pain at all to 10 being the worst pain you've ever had? What's your pain rating?
0.
Okay, he says he's having no pain. That's easy. But let's say that he said that his pain rating was an 8. Well, you would want to ask some more questions. You would want to say, where's your pain located at? And please, can you describe it for me? Like, is it burning? Is it radiating? Things like that. And then you want to document that, the numerical rating, along with the words that the patient used to describe the pain and its location. Next, we're going to measure the patient's oxygenation status. And to do that, you can use a portable probe like this one, or one that connects to a bedside monitor. And to do that, you're going to place the device on the nail bed, because that's where it's going to obtain the reading. So make sure that you pick some fingers that have good circulation. They're nice and warm and pink. So we'll turn on our device and we will place it on the finger and let it get a reading. And here the patient's oxygen saturation is 97%. A normal oxygen saturation is anywhere between 95 to 100%. And below you can also see the heart rate as well, but here in a moment we will actually check the heart rate. And then you'll just want to remove the device, and if it's like a portable one like this, you'll want to clean it with a disinfectant wipe and then document your findings. Now we're going to collect the patient's body temperature. And some things you want to remember about body temperature is that in an adult it can vary. It can be anywhere between 97 to 99 degrees Fahrenheit, with the average being about 98.6 degrees Fahrenheit orally. And in an adult, it's considered a temperature if the temperature is greater than 100.4 degrees Fahrenheit. Now, the temperature reading will depend on the route that you use, and you can take a patient's temperature various ways, like orally, the forehead via the temporal artery, tympanically, which is via the ear, rectally, or axillary via the armpits. And a rule of thumb to remember is that rectal and tympanic temperatures will be 1 degree higher than the oral route, and temperatures that are collected via the axillary or the temporal route will be 1 degree lower than oral temperatures. So we're going to take the patient's temperature using the temporal artery, and we're going to use this device. So what you want to do first is you want to use a probe cover if your device has one. That just protects it from becoming contaminated. And what we're going to do is we're going to hold the probe flush up against the skin at the center of the forehead. We're going to take it and scan it across the forehead to the hairline and look at our reading. And before we do that, you want to make sure that the forehead is clear of any type of hair or anything, because this probe needs to be making contact with the skin. If anything comes into contact with it, it can throw off the reading. So we're going to put it flush against the skin and hold the button in on the device, and you'll hear it beeping, and scan it to the hairline and look at our temperature. Now, if your patient was sweating on the forehead, because a lot of times whenever patients have fevers, they can sweat, you would want to do it the same way. Probe up against the forehead in the middle, hold the button down, scan across the forehead to the hairline, but you're also going to go behind the ear, because sweating will decrease the temperature, and it's very vascular back here behind the ear, and that will just help us obtain a proper reading. Then what you're going to do is you're going to clean your device and document your finding. And if you didn't take it orally, you want to make sure you document the route that you actually took the temperature. Next, we're going to check the patient's pulse. And as we feel the pulse, we're going to be looking at several things. Of course, we're going to be counting the rate, but we're also going to be feeling the strength of the pulse. And we will be grading it on a 0 to 3 plus scale, with 0 being the pulse is absent, 1 plus weak, 2 plus normal, and 3 plus bounding. And the rhythm, is the pulse regular or is it irregular? Now, in adults, the most common site to use to check the pulse is the radial artery because it's really easy to access. So it's found, what you want to do is find the thumb, and it's found below it in this wrist area along the radial bone, hence why we call it the radial artery. And whenever you're checking the pulse, have the patient, they can sit in bed, they can lie down, and you'll want to support their arm, extend it out and support it. And you're going to use your first 3 fingers to feel the pulse. Don't use your thumb. Your thumb actually has a pulse in it. So use your first 3 fingers and find it within that area I just told you. And lightly just touch it. Don't press too hard. And feel the bounding of the pulse. And what you want to do is you want to count it for 30 seconds if the pulse is regular and multiply that number by 2. If it's irregular, count it for 1 full minute. So his heart rate is 82, it's regular, and it's 2+. And a normal heart rate in an adult is 60 to 100 beats per minute. Now what we're going to do is we're going to keep our fingers here because what we want to do next is check the patient's respirations. And if you tell a patient that you're checking the respirations, they're going to alter the way that they're breathing. So we're going to stay in this same position and assess respirations. And when we're assessing respirations, we're looking at a couple things. First of all, the rate. A normal breathing rate in an adult is 12 to 20 breaths per minute. We're also looking at the depth. Is it labored or unlabored? And the rhythm. Are the breaths regular or irregular? And I have found the easiest way to do this is really look at the patient from the side and watch their gown, their clothes. Are they rising and falling? Because 1 rise and 1 fall equals 1 respiration. You can also sometimes just gently take your hand, put it on their back, and feel the rise and the fall of the chest. And so you will count that for 30 seconds if their breathing rate is regular, and then multiply that by 2. But if it was irregular, you would need to count for 1 full minute, and then document your findings. And lastly, what we're going to do is we're going to measure the blood pressure. And to do that, we want to make sure our patient is sitting down with their arm at heart level and their legs are uncrossed. Now, if they're lying in bed, you would want to make sure that this arm is at heart level. Then what we're going to do is we are going to get our stethoscope and our blood pressure cuff. And you want to make sure you get the right size cuff for your patient's arm, because if you use too big of a cuff or too small of a cuff, it can throw off the reading. And what we're going to do is we're going to palpate the brachial artery, because this is the artery we're going to be listening to get our blood pressure, because we're going to be getting our systolic number, which is that top number, and this is the first sound we hear, and then our diastolic number, which is the bottom number, and this is the point where we no longer hear the sound. So whenever we're looking at the gauge of our blood pressure cuff, we want to make sure we're really noting those points, because it's going to tell us our systolic and diastolic number. So what we're going to do is we're going to put our cuff on our patient, and we want to make sure we find the brachial artery. This is the artery we palpate that we'll be using to determine our blood pressure. And it's found in the bend of the arm. So we're going to find it, and it is located here. And we're going to look on our cuff, and our cuff has these arrows. And because this is the left arm, we're going to make sure that this arrow is pointing in that direction of where that artery is. So you're going to put the cuff up about 2 inches above the bend of the arm. First, what we want to do is we want to estimate the systolic pressure. So we want to find that number. To do that, we're going to palpate the brachial artery, and we're going to inflate the cuff until I no longer feel the brachial artery. And at that point, when I no longer feel it, I need to make sure I'm looking at this gauge to know that number, because that number is our estimated systolic pressure number. Then when I go to take the blood pressure, I'm going to inflate the cuff 30 millimeters of mercury more than that estimated number. Now, the whole reason for doing that is because we want to avoid missing the oscillatory gap that can occur in some patients. Not all patients have it, but some. And it's usually patients with hypertension, because the oscillatory gap is like this abnormal silence that can occur, and it will throw off whenever you actually hear that first sound, which is your systolic number. So I'm inflating the cuff by feeling on the artery, and I'm going to note the point where I no longer feel the artery, which is about at the 100. Then I'm going to deflate it completely and wait about 30 to 60 seconds, and then we'll take the blood pressure. So our estimated systolic number is 100. Now I'm going to inflate the cuff to 130, and that will avoid missing the oscillatory gap if one was present. So I'm going to take my stethoscope, put it in my ears. You can use the bell or the diaphragm of your stethoscope. I like to use the bell because it's best at picking up low-pitched noises. So we're going to place that over the brachial artery. Do it lightly. Don't fully compress it because you can occlude the artery. Then we're going to inflate our cuff to 130 millimeters of mercury. And we're going to let it fall about 2 millimeters of mercury per second. And we're listening for that first sound, which is our systolic number. Okay, it's 104. And we're listening for that last sound. And it was 78. So the blood pressure is 104 over 78. Then once you have your reading, make sure you fully deflate the cuff full of air, and you're going to take the cuff off of your patient, of course, and clean it if it's not disposable, and you will document the blood pressure and what arm you took it in. Now, what are normal blood pressure readings? According to the American College of Cardiology 2017 updated guidelines, a normal blood pressure is a systolic less than 120 and a diastolic less than 80. Elevated blood pressure would be considered a systolic of 120 to 129 and a diastolic less than 80. Hypertension stage 1 would be a systolic of 130 to 139 or a diastolic 80 to 89, and hypertension stage 2 would be a systolic greater than 140 and a diastolic greater than 90. Okay, so that wraps up this demonstration on how to check vital signs. Thank you so much for watching, and don't forget to subscribe to our channel for more videos.
Okay, so normal vital signs. Please note the following parameters are given by a prescribing physician and report findings to the director of nurses or your administrator for further instructions. We as med techs are not LVNs, we're not RNs, but however, sometimes medications will come with a parameter. It's really important before giving medication that we discuss it with the physician if it's outside of the written orders. So a person's temperature, blood pressure, blood pressure and respirations will be used within a 24-hour period. For medication, sometimes the orders say to take a vital prior to the medication, after a medication, but typically we're doing vitals about once every 24 hours. Temperatures, 98.6 is the normal oral, 98.8.6 is usually for temperatic, sorry. Rectal is usually a degree higher, and axillary is going to be a degree lower. Ideal blood pressure is 120 over 80. Respirations are 16 through 23, and pulse rate is 60 to 100 with our pulse rates. Bear in mind, if a pulse is above 100, have the resident rest. A lot of times they could just came back from the bathroom. They could have just changed positions in bed. So retake that pulse if it's higher. When it comes to our oxygen saturations, which I just realized I forgot to put on that slide. When we are dealing with somebody who is on oxygen, please note if you take somebody's pulse ox, oxygen saturation with the finger, and let's pretend it says it is 89. You do not, I repeat, you do not change that oxygen setting. Oxygen is a medication. And a lot of our seniors have what is called COPD. And COPD, the way our body processes oxygen and carbon dioxide is much different chemistry in these individuals. And when we give them more oxygen, we are putting them at risk of actually becoming less oxygenated. And so, for example, when I worked on the floor as a respiratory therapist, I had a nurse one time call me frantic. And she had a patient who was on 2 liters nasal cannula, and that's in the nose, and her patient had went from a 96 to a 92. So she bumped him up to 4 liters, which was okay. But then he went from a 92 to an 89% room, our oxygen level. And so she goes and gets a mask and she cranks him up to about a 7 or 8 oxygen liter. And now his oxygen saturation's dropped even more, and she's calling me and she's panicking. She's a new nurse. But what she didn't realize was the body didn't have enough time to process this oxygen, and it was actually causing the cells to hold on to the carbon monoxide a lot longer. And so an attempt of what she thought was doing some good was actually causing some harm. So please, I just cannot stress this enough, you guys. Don't touch the oxygen. Call the hospice company, call the home health company. Have the nurse come out and assess and have her or him adjust that medication, which is in this case the oxygen. Please don't ever feel like you're assisting them by upping their oxygen levels. Unless there is a written order, you are to not touch that oxygen. All right. Some residents may have parameters for certain medications, such as blood pressure medications. You can assist the resident by applying the blood pressure cuff. Be sure the cuff is applied correctly. So there is a little spot that says artery over here, as shown in the video. And you're going to instruct the resident to push the button themselves. You're going to review the MAR with the resident and give the medication as ordered. So with these parameters, we are not interpreting them, but we're assisting the resident in interpretation of the medication order. Because once again, we're not clinicians, right? And we cannot read an order with a parameter, but we can assist the resident in making sure they read the right parameter for themselves. Some medications may be held based upon a blood pressure reading. If this happens, you need to do a communication, med communication, and send this into the physician and inform them of medication being held and why. Be sure to document the blood pressure log and the reading, and if the medication was held or not. If a resident is nonverbal, contact the director of nurses, the administrator, or your clinical liaison after blood pressure reading to give the directions and on how to proceed with the order. If the resident is reporting being dizzy, shortness of breath, chest pain, swelling of ankles, call 911 and send the resident out for a medication and medical evaluation. Many of these symptoms are indications of serious health changes and conditions and may require medical attention. So, when it comes to cardiac issues, a lot of times one of the first warning signs is going to be extreme swelling in our extremities, especially the feet. And what happens is the heart has a hard time pumping the blood back up through the body. And so, because of gravity, it will pull in the ankles and the feet. So, if you notice that your resident, especially a resident who's on any cardiac or blood pressure medications, has extreme swelling in their extremities, it is very important you seek medical attention for them. All right, video time. So if you've gone through the caregiver training, you've already seen this video on how to wash your hands, but it's always good to review. So I hope you all in between your residents, if you're passing out meds, you've got your hand sanitizer and you're pumping the hand sanitizer. You're changing your gloves when appropriate. And when you're washing your hands, we're singing that ABC song. I know you guys all probably thought it was a little corny when I did it the first time, but we're gonna sing A, B, C, D on top of our hand. We're gonna go to other side, you know, and you're going to get the wrists, LMNOP, right? And you're gonna get your fingernails and your beds in between all, right? And you're gonna sing it all the way to Z, okay? And then you're gonna rinse really good, right? You're going to use a paper towel, turn off the faucet, and you're going to use a dry paper towel to turn off that faucet, not the paper towel that you just used to dry your hands off with. So with no further ado, hand washing.
For the COVID-19 response in long-term care facilities. Today, we are going to talk about how clean hands combat COVID-19 and discuss some key points for understanding the role of hand hygiene in COVID-19 prevention. This is part of the key COVID-19 prevention messages for frontline long-term care staff. The residents you care for in nursing homes and assisted living facilities are the most vulnerable to COVID-19 infections. Because of their age, frailty, and chronic medical needs, nursing home residents are more likely to have severe illness leading to hospitalizations and deaths. 8 out of every 10 deaths from COVID-19 have occurred in adults over 65 years of age. We all must take action now to protect them. You've probably heard a lot about hand hygiene before, but did you know that nursing staff can touch up to 15 different surfaces during a single care interaction? That means an average nurse working with 5 residents each hour would be expected to touch over 900 surfaces during a shift. Viruses like the coronavirus causing COVID-19, bacteria, including C. diff, and other germs can all be spread from our hands to our residents, their care equipment, and other surfaces in the room. Cleaning our hands often during these interactions contains their spread. There are 4 important moments when you must clean your hands: before any contact with the resident or their environment, before every cleaning procedure, such as placing a urinary catheter or a peripheral IV, after handling soiled items or body fluids, including after emptying a urinary catheter collection bag, and after touching the resident or his or her environment. If you clean your hands at each of these moments, you will be doing your best to protect your facility. You've probably had many in-services about hand hygiene technique, but did you know that alcohol-based hand sanitizers are preferred by the CDC for most hand hygiene opportunities? Hand washing is recommended when hands are visibly dirty or contaminated, such as after caring for residents with infectious causes of diarrhea, like norovirus or C. diff. Why does CDC prefer alcohol-based hand sanitizers? Well, it's because they are extremely effective against coronavirus, influenza, and many antibiotic-resistant germs. In fact, studies have shown hand sanitizer is more effective than washing hands with soap and water. Why? Because the alcohol hand rubs and gels start killing germs immediately. These products are easy to use because they coat the surfaces of your hands and aren't relying on perfect technique or a certain amount of time. Also, you can put up hand sanitizer dispensers all over the building, at the bedside even, which is hard to do with sinks. And the good news is that hand sanitizers are less drying and less hard on your skin than constantly washing your hands with soap and water. We don't always think about it, but our nails can actually provide a safe space for germs to hide, away from the killing effects of soap or sanitizers. Although we all enjoy pampering our hands with manicures, people taking care of residents should really avoid artificial nails and keep their natural nails trimmed. That way, we aren't taking a chance that our hand hygiene isn't effectively getting rid of all the germs. We all use a lot of gloves during resident care, but we have to remember that while gloves protect our hands, they are not a substitute for hand hygiene. We should be cleaning our hands after every glove removal and making sure we don't accidentally use the same pair of gloves with more than one resident. We don't realize how much we touch faces, our hair, or our clothing during the day. So be mindful of what you're touching, and definitely don't touch yourself or reach into your pocket with gloved hands. Also, although we are trying to conserve our use of personal protective equipment, we should not be washing gloves with soap and water to try to use them again. So remember, clean hands protect everyone, you, your residents, and even your family. Do your part to stop the spread of COVID-19 by cleaning your hands frequently and reminding others to do the same. We are all in this together, and sometimes it helps to have a friendly reminder when we get busy. Support your residents in cleaning their hands too, before meals, after toileting, and throughout the day. If they have clean hands, then everything around them also stays a little cleaner. Bring your good hand hygiene practices home as well, so you, your family, and your community all stay safe. Here are links to a variety of resources available on the CDC website. They provide more information about COVID-19, additional guidance, and tools. Thank you.
In this video, we'll walk you through setting up and using your Accu-Chek Guide blood glucose meter. Now, if you're worried about learning the steps involved, don't be. This video is divided into small sections, so if you miss anything, you can always go back and watch that part again. Now, the first thing to do is to make sure that you have everything you need to start testing. You should have the following items: an Accu-Chek Guide meter, an Accu-Chek Guide Smart Pack with test strips, an Accu-Chek SoftClicks lancing device, and an Accu-Chek SoftClicks lancet. If you can't find something or if you need assistance with any of the steps that follow, just contact Accu-Chek customer care. Next, let's walk through setting up and using the Accu-Chek SoftClicks lancing device. First, you will need to load your lancing device. For this, you will need an Accu-Chek SoftClicks lancet. Remove the cap from the lancing device. Now insert the lancet into the lancet holder as shown. Push it all the way in until it clicks in place. Twist and remove the protective cap from the lancet to expose the needle. Place the cap back on your lancing device. Be sure to align the notch on the cap with the mark as shown. The next step is to set the penetration depth to match your individual skin type. By turning the dial on the cap, you can select the depth of the lancet. Set the dial to 2 to begin with. You may need to adjust the setting a couple of times until you find the right level for your skin type. To use the lancing device, you first need to prime it. Press the priming button all the way down. The release button on the side of the lancing device has now turned yellow. This indicates that your lancing device is now primed and ready to use. Press the yellow button to release the lancet. This will lance your finger. This part is important. Accu-Chek SoftClicks lancets are disposable and should only be used one time. A reused lancet is no longer sterile, will lose its sharpness, and become more painful each time you lance your finger. When disposing of a lancet, always make sure that it cannot cause injury and always use a sharps container. To dispose of the lancet, remove the cap from the lancing device. To remove the used lancet, point the lancing device into the sharps container and eject the lancet by sliding the ejector forward, then put the cap back on the lancing device. Now you're ready to do a test. First, you'll need to choose a finger to take a sample from. It's best to alternate between fingers as they can become sensitive over time. Remember to always wash your hands with warm, soapy water and dry them thoroughly. Take a test strip from the Smart Pack, the spill-resistant test strip vial, and always remember to close the lid tightly. This helps protect the remaining strips. Insert a fresh test strip, metallic end first, into the meter, and the meter will turn on. Notice that the test strip port light allows for easier use in darker environments. Now it's time to use the lancing device. Place the pinhole opening firmly against your finger and press the yellow release button. This will lance your finger. Massage the finger in the direction of the fingertip to help the blood drop form. Touch the yellow edge of the test strip to the blood drop. When enough blood has filled the strip, Analyzing appears on the display. Remove your finger from the strip. A small hourglass symbol will rotate on the screen to show you that the meter is working. Your blood sugar reading will be ready in less than 4 seconds. It's just that easy. And now you have your test result. The meter can automatically display your previous result too, so you can compare blood glucose levels. This feature may be turned on in the settings menu. One important final step. Dispose of the used test strip by pressing the strip ejector button on the right side of the Accu-Chek Guide meter. Then put everything in the carry case. You'll find more information in the user's manual that came with your meter. If you still have any questions, please visit accuchek.ca. Thanks again for choosing the Accu-Chek Guide Blood Glucose Monitoring System.
Okay, we are back after that quiz. I hope you're feeling confident in what you're learning here today. We are going to go into glucose testing. So, the number one thing to remember when it comes to glucose testing is that we are assisting the resident with their diabetic care. And what this means is that you should never be the one to physically poke a resident. You could do what is called a handover, a hand method technique, but they should be able to perform these tasks fairly independently with maybe some general oversight. The first step is that you're going to wash your hand and sanitize your hands before beginning the task. You're going to locate the equipment in the med cart that belongs to that resident. Do not use equipment intended for others. Sometimes there are some of our residents that are on telehealth programs. And so if you used a glucose monitor that was intended for Mr. Allen and Mrs. Smith uses it and she has a very abnormal reading, that could affect the care for Mr. Allen because that is automatically Bluetooth transmitted to the physician for review. So please be careful of the equipment and make sure we're using the correct equipment. Help the resident warm their hands if necessary. Use the alcohol wipe on the finger to make sure that the finger is very well sanitized. Apply the gloves and assemble the glucose monitor, the poker, ensuring a fresh needle is used every time, and when it is done, and that it's disposed in the sharps container. Do not dispose the sharp in the med destruction bin. Do not dispose medications in the sharps container. Okay, it's really important that we keep those two separate. Have the resident use a poker, disregard the first squeeze of blood, and then wipe the finger with an alcohol pad, and then squeeze a new amount of blood to be used on the monitor. Have the resident place the drop onto the test strip, wait for the reading, and record it into the resident's file. We should be keeping a glucose log even if they're on a telephonic system, because sometimes the equipment can fail. So you should be, applying in the log the date, the time, the reading, if there was any medications to be given or held, and then your initials or your name so we know who did the reading. Have the resident wipe their finger, hold the gauze to stop the bleeding, and dispose of any bloody gauze into that sharps container. That is one thing that can go into the sharps container, is anything that is biohazard that has any bodily fluids on it. If the resident has insulin orders, this is where you're going to refer to the MAR for additional steps. Once again, if they're on a sliding scale, the resident needs to be able to help you interpret what dosage of medication they should be getting. You should also contact your clinical liaison or your director of nursing if you're at a location that happens to have a LVN on staff for further instructions. You should also be informing the administrator if the insulin reading, or sorry, not insulin reading, the glucose reading is very abnormal for additional steps as well. Okay, so the next video is going to be on how to set up and use an insulin pen. Please note, if a resident is ever admitted or comes back from a primary physician or a physician's office with a vial of medications for insulin, that you have to inform them right away that we need insulin pens. Insulin vials require a special skill set that we are not licensed underneath the state of California to perform. And we don't always have an LVN available 7 days a week if you're at one of the locations with an LVN. So it is really important that we use insulin pens only. And this video is going to show you how to set up and administer insulin through an insulin pen.
Hi, I'm Dr. Emily Walker, a VA pharmacist, and I would like to discuss with you the proper way to give yourself insulin using an insulin pen. There are many different types of insulin pens available from the VA. In this video, I will be demonstrating one specific type of insulin pen called the Flex Pen. Other names of insulin pens prescribed by your provider may include Flex Touch, Solistar, or Quick Pen. What is important for you to know is that the correct technique that I will show you in this video is very similar to what you would use for any of the other insulin pens mentioned. Remember, what insulin to use, how much to give, and when to give yourself the insulin will be told to you by your VA provider. Let's get started. When you're preparing to give yourself insulin, you want to make sure that you place all the proper supplies on a flat surface ready to go. These supplies include your insulin flex pen or whatever insulin pen you may be using, your pen needles, an alcohol swab, and a sharps container. If you do not have a sharps container, you can use a heavy plastic container such as an old laundry detergent bottle and write used needles on the side with a permanent marker. Before injecting yourself, wash your hands with soap and water. When your hands are dry, pull off the pen cap from the insulin pen and set it aside. Next, inspect the insulin through the viewing window. Do not use the insulin if you notice a change in color or if you notice things floating in the insulin. By inspecting the insulin pen, you will also be double checking that you have the correct type of insulin. As I mentioned already, for our example today, I am using the Novolog Flex Pen, which has been pre-filled with insulin aspart. After inspecting the insulin pen, put it down and open an alcohol swab. Wipe the rubber stopper on the end of the insulin pen with the swab. Allow the rubber stopper to air dry completely. Do not blow on the rubber stopper to dry it, as this will introduce germs from your mouth. Next, pick up the pen needle and remove the protective paper covering. Grasp the base of the pen needle and carefully screw the pen needle onto the insulin pen. Make sure the pen needle is screwed on straight and hand tightened so that it pierces the rubber stopper completely. Make sure you do not over tighten the pen needle, as the pen needle base is plastic and can crack. Next, pull off the clear plastic outer needle cap. You will see a second inner needle cap still covering the needle. Remove the inner plastic needle cap. Both plastic caps can be disposed of in your regular household trash. It is important to always use a new pen needle for each injection to reduce the risk of infection. Never reuse or share needles with your family or friends. Next, we will complete an air shot with the insulin pen, which should be done before each injection. An air shot is sometimes called priming. Doing so removes any air that is trapped in the needle. Turn the dial up to 2 units. Hold your insulin pen with the pen needle pointing straight up and lightly tap the insulin pen with your finger a few times to make sure any air bubbles move to the top. Next, press the push button all the way in. The dial should return to 0. You should see a drop of insulin appear at the tip of the pen needle. If the drop does not appear, repeat the process. This can be repeated up to 6 times. If it still does not work, try using a new pen needle. If that doesn't work, then try a new insulin pen. Next, select your insulin dose. Check to make sure the dial is set to 0, then turn the dial selector to the desired number of units. The pointer arrow should line up with your desired dose. The dose can be corrected up or down by turning the dial. For example, if you are prescribed insulin aspart 10 units before meals, you will dial up to 10 in the pen window while making sure the arrow lines up with the desired number of units. Be careful not to press the push button while selecting your dose, or the insulin will come out prematurely. You will hear a click for each unit you dial. It is not recommended that you attempt to dose based on how many clicks you hear, as this may result in an incorrect dose. Please note towards the end of the insulin pen use, you will not be able to dial more than the number of units remaining in the insulin pen. Next, if your skin is not clean, use an alcohol swab to clean the site before injection. If you just bathed, you may not need to clean the area with alcohol. Remember, alcohol can be very drying to your skin, so you don't want to apply alcohol to your skin if not needed. Insulin can be injected into either your abdomen or stomach area, buttocks, on the high hip upper outer area, thigh, or upper arm. That is the back, fattier part of your upper arm and not the muscle area. The needle you are using is thin and may bend. You may find that pinching your skin gently before injection can prevent bruising and decrease the chance of bending the needle. It is recommended that you rotate to different sites each time you use the insulin pen. If you plan to be physically active right after the injection, it is recommended to rotate around your stomach area only, rather than to the arms, legs, or buttocks. Avoid injecting insulin into any area of skin that has pits, is thickened, or has lumps. Avoid injecting where the skin is tender, bruised, scaly, or hard. In addition, stay 1 to 2 inches away from your belly button, scars, or skin with open wounds. If you are injecting more than one type of insulin, use different injection sites, as the insulins won't work as intended if injected in the same site together. For instance, give your basal or long-acting insulin on the left side of your stomach, and then give your bolus or rapid-acting insulin on the right side of your stomach. Insert the insulin pen into your skin straight in and not angled. Again, if there is not enough fatty tissue, pinch a 1 to 2 inch portion of skin in fat. Once the insulin pen needle is inserted into your skin, keep it in place and press the push button on the insulin pen all the way in, and maintain it pressed until the arrow next to the dial returns to 0. Keep it pressed for a full 6 seconds after the dial is at 0 to make sure all the insulin is injected. Now you can remove the insulin pen. A small drop of insulin may appear at the end of the needle. This is normal and can be expected. If a drop of blood appears on your skin after you remove the insulin pen, press the injection site lightly with a gauze pad. Do not rub the area. Once the injection is completed, do not recap the needle, as this can cause an accidental needle stick injury. Remove the pen needle from the insulin pen by grasping the sides of the plastic hub and twisting. Discard the pen needle into the sharps container. Place the pen cap back on and store the insulin pen in a safe location. Your insulin pen can be stored at room temperature, below 86 degrees Fahrenheit, for up to 28 days, away from heat or light. It is recommended that you keep your unused insulin pens in the refrigerator between 36 to 46 degrees Fahrenheit, as the insulin pens can be safely stored until the expiration date on the label. Never freeze insulin. When the insulin pen has been completely used up, it will not allow you to give any additional doses. At that time, you can discard your insulin pen with the pen needle removed into your household trash. The pen needles should always be placed into a sharps container. You have successfully given yourself a dose of insulin.
How to assist a diabetic resident. So how to direct and guide a diabetic resident to perform blood glucose checks and insulin administration. So we are going to, use a hand sanitizer. Again, you shouldn't, if you're, assisting the same resident, you shouldn't have to go and wash your hands, okay? Check your MAR, triple check time, order the directions on the pen and your MAR, okay? You're going to hand an alcohol wipe to the resident, and they are going to clean the site for the injection. Don't forget, you're going to have to express any error in the insulin pen. So you're going to do a click or two, remove the error, and then you're going to re-click it to the appropriate unit dosage amount. And you're going to actually encourage the resident to do the pin clicking themselves. They might need you to watch the window and make sure that they have, 5 units and not 15 units. on the little window for the pin. And you're going to have the resident poke themselves. If they have difficulty in pushing the stopper, the button on the end of the pin, you can assist with a hand over hand to push the plunger down, but they really should be engaging in this on their own. Take the bigger cat. So the resident's going to remove the pin out of their area that they've injected, and you're going to take that bigger cap and you're going to put it over that needle, and then you're going to twist it off to dispose into the sharps container. Okay, so next we're going to go into a video with the different types of insulin and why we give them and how we give them. It's really important that you understand this because some insulins require at bedtime, some insulins required before meals, some insulins required after meals, and it's all based upon their mechanism of how they work. And it's really important that you understand that when you have a resident who is a diabetic, that you never go rogue on your own and decide to give them insulin outside of an order or an order set. The reason being is not all insulins are created equal. So you could be giving somebody a long-term acting insulin thinking it's going to be a short-term acting insulin and it's going to take effect immediately. And in reality is that you can cause a diabetic crisis 12 hours from now because you have given them too much of the wrong medication. So please watch this video. How to help the resident with their insulin is a very key part of being a med tech. So make sure you explain to the resident, why they're on insulin and things that they can do to help maybe reduce the need of so much insulin, like switching from a sugar in their coffee to maybe a Splenda or Equal in the morning. Okay. There are many different types of insulin. It's important to know what you're giving your resident when they receive it. Some insulins are once a day, some are just before meals, and they can act very fast on the resident system. It is extremely important that you do not give, that you understand that you only give insulins as ordered and when ordered, and that you do not give them outside of these ordered times. Even if your residents' glucose levels are high, I cannot express this enough. Do not go on your own and decide to give something because you think you're helping, because you could be causing harm. If a resident only receives insulin once a day and glucoses are higher at dinner time, do not give without a written order. So you might call the physician and let them know that, hey, Mr. Smith's glucose was really high, and Mr. Smith's doctor might recommend that you give 10 units of insulin. But however, do not give that insulin without that order, because you might have heard 10 and he said 1. A normal glucose level is less than 140 and no less than 75. Some providers will establish different levels for each resident. So it's really important to know what the doctor's recommendation is for that resident. Anything above 250 needs to be reported to a LVN if you have one on site, the physician, and document in the resident's files. It's really important to understand that if you have a resident who is frequently has sugars that are above 250, that you have a conversation with the doctor about making medication adjustments. And if you feel like you're not really getting anywhere with the physician, it's really important that you have a conversation with the administrator or the LVN, so they can also have a conversation with the physician and or pharmacist or potentially the family member if they need to get the family member involved to make medication adjustments. It's also really important that if you have a resident whose blood sugars are extremely low and you cannot get their glucose levels up with some juice or something, that they get sent out to the hospital immediately. And the same thing with high blood glucose levels. If somebody's over 350, we really should be calling 911 and asking them to be taken in for a medical evaluation unless there's an order set that says differently. Many times, the physicians might not realize what's going on if we don't communicate. Sometimes residents might return back from an appointment with a vial. As mentioned before, we cannot have vials in the ALF setting or memory care. So it's really important that we get an order for a pen. If the medication cannot be switched out for some reason, we might have to look for placement elsewhere. Okay, so the next video is going to be on how to recognize high blood glucose levels and low glucose levels in our diabetic residents and how we could potentially assist.
It can be important to recognise the difference between low and high blood sugar symptoms. Being able to spot when your blood sugar is high or low can help you to manage your diabetes. Where possible, it's best to check with your blood glucose meter whether you are high or low before taking any remedial action. The symptoms of high blood sugar can include increased thirst, dry mouth, increased hunger, frequent need to urinate, feeling lethargic, blurred vision. If blood sugar is regularly high, then you may get recurrent episodes of thrush. Very high blood sugar is serious and can result in nausea, vomiting, or loss of consciousness. In type 2 diabetes, this can in the form of a condition called hyposmolar hypoglycemic state, and in type 1 diabetes in the form of ketoacidosis. It is important to seek emergency medical help. Symptoms of low blood sugar can include increased heartbeat, strong hunger, weakness, clumsiness, confusion, dizziness, difficulty concentrating, slurred speech, tingling in the lips or tongue, irritability. Very low blood sugar can lead to convulsions and unconsciousness. It is important to seek emergency help if the person with diabetes is unable to bring their sugar levels back to normal. The University of Birmingham's Medical School states that if the body becomes used to being low on sugar, hyposymptoms can become less noticeable. Loss of symptoms of low blood sugar can in particular be dangerous. If you have difficulty recognising the symptoms of hypoglycemia, speak to your doctor.
I'm going to talk us through what to do to bring down higher blood sugar levels. The classic signs of high blood sugar levels are feeling very thirsty, needing to go to the toilet to urinate a lot, and feeling tired, lethargic, and possibly irritable as well. The symptoms of high blood glucose levels can be similar to low blood glucose levels. So, if you're on medication that can cause you to go hypo, it's a good idea to check your blood sugar levels before you attempt to bring them down. This is particularly important if you're taking insulin. If you're on a flexible insulin regime and control your own doses, you can use insulin to bring your blood sugar levels down. Be wary of any insulin that's already in your body, and don't be tempted to overcorrect. Walking is a good way of bringing your blood glucose levels down and can be better than strenuous exercise. More intensive exercise can initially push blood sugar levels up in some people, so walking may be a better option. If your blood glucose levels are on the higher side, around 10 or more, your kidneys will try to take sugar out of your blood. Drinking water can help the body along with this. Just a word of caution, don't be tempted to drink too much more than a litre of water in a short space of time, as, whilst rare, drinking too much water can lead to water intoxication. So, in summary, if you're not on a flexible insulin regime, your best bet for lowering blood glucose levels is to take a walk and keep.
Most of us understand the importance of a normal blood glucose level. If our blood glucose level goes very low, we might become unconscious. If our blood glucose level goes very high, we develop a problem called diabetes. Now, diabetes is serious. It can cause damage to the larger blood vessels in our body. So diabetic patients have a very high incidence of heart attack, stroke, as well as amputation. But diabetes can also cause problems to the very small blood vessels in the body, so-called microvascular problems, resulting in damage to the retina. Diabetics have a high incidence of blindness. It can also cause problems with the very small blood vessels supplying the kidney. So diabetics have a high incidence of kidney failure. Now, what exactly is a normal blood glucose level? Well, to put it in terms that most people can understand, including myself, I have here a container with 5 litres of water within it. And the reason I've chosen 5 litres is because the average person has about 5 litres of blood circulating around the body. I have also a container of glucose, a white crystalline powder, and you might be surprised to know that the amount of glucose that I would need to add to this container to give a similar concentration of glucose in my blood is only 1 teaspoon. In fact, it's slightly less. It's about 4.5 grams. So here's the glucose, and if I add that to this container, the concentration in there is approximately the same as the blood glucose level in my blood right now talking to you. Now, if I were to add another teaspoonful, the concentration of glucose now in this water is that of a diabetic. So as you can see, the blood glucose level is very tightly controlled, and the difference between a normal blood glucose and that of a diabetic person is only an additional 1 teaspoonful of glucose. Quite surprising, really. So, how do we maintain normal blood glucose levels during the course of the day? Well, many people are advised to eat small, frequent meals throughout the day, consisting or having as part of that meal or snack a complex carbohydrate which releases glucose very slowly into the bloodstream. However, more recently, many experts have challenged this view, and I'm of the view as well that we don't actually need frequent meals containing complex carbohydrates. In fact, Professor Tim Noakes, in his excellent book, The Real Meal Revolution, has suggested that actually there's no requirement for us to eat carbohydrates at all. And certainly the liver has an amazing ability to manufacture glucose should it be required. Certainly for people with type 2 diabetes, in which the main problem is too much glucose in the bloodstream, many experts, and myself included, believe that the way to tackle this issue is to eat meals which have a restricted amount of carbohydrate within them. Because all carbohydrates, when they're eaten, are digested, and they have to enter the bloodstream as glucose. And as you can see, it doesn't take very much glucose entering the bloodstream to turn a normal blood glucose level into that of a diabetic. So it seems sensible, if you have a risk of diabetes, then to restrict the amount of carbohydrate that you're eating. We don't need, there's no essential requirement for carbohydrates, in fact. We can exist very happily with proteins and fats. We don't actually need to eat carbohydrates. And as I say, the liver has an ability to manufacture glucose and release it into the bloodstream, a process called gluconeogenesis. So that's a normal blood glucose level. Only 1 teaspoon in 5 litres gives a concentration of glucose which is equivalent to that of a normal person. It doesn't take very much more to tip one into a high blood glucose level, the same as that of a diabetic. And so for those who are at risk of developing type 2 diabetes, in fact, some would say for all of us, it's sensible to restrict the amount of carbohydrates that we eat.
Here's the procedure for the disposal of sharp objects, needles, and syringes in the clinic. First, locate an approved hard plastic container with lid that's ready and near your workstation. Here we have one for sharps, and here we have one specific for glass. Sharps can include, but are not limited to, razors, needles, glass, and needles in syringes. Never recap or resheath your needles, lancets, or syringes. Never remove the needle from the syringe or break off or blunt the needle's sharp end. Always dispose of your sharps immediately after use. Don't walk unnecessary distances with a sharp in hand. And never hold the container or support it with your bare hands. Hold the sharp by the blunt side with the sharp face pointing away from your body. Don't try and catch a sharp should it fall. Do place the sharp face down into the container, but never place your hand into the container. Wash your hands immediately after disposal, and should an accidental cut or needle stick occur, notify your supervisor immediately.
To assess diabetics and their care, that you take steps to protect them and yourselves from accidental needle pokes. If a needle poke occurs and it was a resident's needle, you need to inform your supervisor right away. There are going to be things that you're going to need to do in order to protect your health. Never recap a needle. You'll see that sometimes nurses will do, like they call it the one scoop method, where they, kind of scoop the needle cap up and then they'll cap it. Never ever do that. Just throw a needle into the sharps container. With the insulin pens, those caps are fairly resistant. And if you're turning them in the right position, you are safe from a needle poke. If you try to uncap it, though, however, without that cap, that protective cap being put back on, you are risking yourself at a needle poke, okay? Never keep them in your pockets. I know sometimes we like to keep extra supplies in our pockets in case we need when we walk into a room or something, but you're putting yourself at a risk. And never ever force a sharp into a sharps container if it is full. You are better just to put it into an empty container on the side and then put the contents of that container into a new sharps container. Never force open a sharps container. And if your sharps container is full and you cannot locate a new one, notify your supervisor immediately. So we're going to go into preparing the med cart. So this is the typical medication cart that you will see in a variety of care settings. You'll notice they've got plenty of cups and straws. They've got their water ready to go. They've got their MAR on top, and they've got a clean service for medication preparation with a little paper towel there. So you should check your medication cart to the prior of the start of your shift. And so what this means is you shouldn't be arriving exactly on time for your shift. Come 5-10 minutes before. Start looking at your cart. Make sure you've got plenty of cups and all the necessarily supplies that you're going to need. And this includes a fresh a pitcher of water, spoons and medication cups, applesauce and yogurts, tissues, and your medications crushing device. You should have a medication drug book handy. And the reason is maybe there's a new medication and Mrs. Smith is going to ask you about it. So it's really important to, be prepared for questions that the resident might have. And if you don't know an answer to a question, please don't just say anything that you think sounds appropriate. The best answer is, I don't know, but let me find out and I'll get back to you. And that's when you contact the supervisor. So your MAR, do not use your own individual notepad to write down medications and use that in replace of your MAR. I've seen med techs do this, and it is absolutely not appropriate. If you're going to take 1 or 2 medications with you, take the whole MAR book or take that MAR sheet with you. Do not use your own notebook for the purposes of administering medications.
First, you're going to have a lock that looks like this. It's very easy to put in and take out. They're on the larger side of the locks. I'm sure Dave is going to have a process for all that. But the locking system is very easy, just like that. That is, and then it unlocks. The keys can just stay in that. And of course, we can't have meds unattended. We also have to have this locked when we aren't by it, so it has to be locked when unattended. When you look at the structure of it, there's a big surface area. You can see the MAR books are the same in all the towns, and there's a lot of space when you look at that. These MARs, of course, have that little bit of rubber on there, so when you're, backing it against a wall, that they'll stay up easily when you're doing your med pass. There are 3 drawers on the smaller side on the left, and then the 3 larger drawers on the right. It is locked and secured with these locks here. Very easy to push them, and you will be able to lock it, and it becomes not obviously very mobile at all. And there is a lock on this one back here that you can lock as well. However, when those locks are not engaged, this is a very easy, I can even pull it and push it with one hand. So it's very mobile. The drawers are of large capacity. Oh, one more thing I wanted to show you, I'm sorry. There is a pull-out drawer, and that pull-out drawer can be utilized during your med pass, and it can handle up to 20 pounds. And so we don't want to break that or put anything else on there, but that is the way the pull-out drawer looks. So again, these drawers can be utilized per home, specific to what you guys want. The nursing team will be available for managers and queues to talk, and people supported to talk about what this looks like, how they want to store the items in their home, because each house is going to be a little different. So I have a variety of things here to show you. So in the first drawer, I just wanted to say there is a booklet here, product catalog. When you think about the things that you need in a med pass, I'll tell you it looks nice to have that paper towel there, but the paper towel, it doesn't shut. So we'll have to have something for that. Even the paper towel can just, hang right here and be utilized. Also, this does sit straight up. The Clorox wipe does, because of course you have to clean it before and after each use. This is high quality. It can be sprayed with antibacterial spray, or a Clorox wipe can be used between uses. Of course, internal and external meds have to be stored separately. That is for sure what we need to have. This is not really a nebulizer, but it is a box, and that just shows you the size of items that can be in there. And this is just an acrylic tray that I had, and they're able to be in there. There are some hooks here that I suppose if you got real creative, but that is a very deep drawer. And if I didn't say it, internal meds and external meds do have to be stored separately. So I'm thinking these could be the places where you have that storage. I have a little basket in my office, and so I put it on there, and that basket is utilized. Might be something that people are interested in doing. It certainly could be when it comes down to whatever drawer. Maybe this is where the pens and the cups go. I mean, there's a lot of things that you can do. Again, it's going to be specific to your house. And of course, a lockbox for controlled substances. They sit in there very easily. When we open these big, large drawers, again, you don't have to set it up this way, but I do have that large container here, and I have med cups, if you can see them, and water glasses, and of course, it's just a plastic tray. I also have what we commonly see on people's desks, and just so that you know the size, that will hold it. And of course, we could have paper clips or alcohol swabs, whatever that person supported would need, or whatever the staff need to handle meds. And of course, these drawers are so deep, I don't necessarily have dimensions, but it is easily seen how these plastic containers easily fit in there, and they fit depending on how that situation will go. And I don't have anything there. I have put some binders in there, and of course, binders fit in there. They stack up nice if you have a start and a stop on there. So these medication carts are going to be implemented as soon as we can get them into the homes. And they're going to be used when we have med passes, so that the person supported can go in their room and have a private med pass.
All right, so we are going to go into our next video, which is our metered dose inhalers. And we're going to have another key phrase, and our key phrase is going to be nebulizers. So the key word to make sure that if you're watching this video independently is nebulizers.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to demonstrate for you how to use a metered dose inhaler using both the open mouth and closed mouth technique. So what is a metered dose inhaler? This is an inhaler used to deliver a set amount of medication into the patient's lung. And the medications include like bronchodilators like albuterol. A brand name for that is like Ventolin or ProAir, along with corticosteroids such as fluticasone, which is known as Flovent. And patients who have respiratory diseases like asthma, COPD may be prescribed these inhalers. Now, these inhalers can also be used and be ordered as a combination where there's one inhaler, but there's two different types of drugs in them, like Symbicort, which would contain a bronchodilator and a corticosteroid. So you want to keep that in mind and always look at what your patient's going to be taking. Another thing is that you want to teach the patient proper technique when using these inhalers, because if they don't use them correctly, what will happen is that not a lot of the medication will get down into their lungs. It'll just stay in their mouth. And that is a big issue with some of these medications like corticosteroids. So whenever you are teaching the patient how to use an inhaler, try to get a spacer. This is what it looks like. And it attaches onto the inhaler and they inhale through that, which I will be demonstrating in the next video how to use. But if a spacer is not available, you can use the open or closed mouth technique, and always go by whatever the physician has prescribed for the patient. A lot of the patients will tell you what they've been using, and you need to make sure that they're doing it right. Now, why would you want to use a spacer? Well, the spacer is going to be easier to use than that open mouth, closed mouth technique, because whenever you're using this inhaler with those techniques, you have to simultaneously press the inhaler down and inhale at the same time, which takes a lot of practice. So if you have a really young patient or a patient who's older who has issues with holding the inhaler, that can be troublesome. Also, the inhaler in the chamber is going to allow this, in a sense, lead time for them to inhale the inhaler substance so they don't have to press it down simultaneously, and it's going to decrease the amount of medication that's going to be left in the mouth, which with corticosteroids we don't want that because it can cause mouth irritation like thrush. So what we're going to do first is we're going to perform hand hygiene, and we're going to perform the patient's 5 rights. We're going to make sure that we have the right patient, the right drug, the right dose, we're doing it at the right time, and the right route. And you always want to look at what you're giving, because whenever you're doing these inhalers, there's some things you want to keep in mind. Okay, say you were going to be giving a bronchodilator inhaler and a corticosteroid inhaler. So you have 2 inhalers. It's very important you know which one you need to give first. The first one you want to give is the bronchodilator because it's going to open up those lungs and dilate that. Then you need to wait 5 minutes and then administer the corticosteroid, because then the corticosteroid can get in there and do its job by decreasing the inflammation. Now, say you were giving 2 puffs of a bronchodilator and that was it, or 2 puffs of the corticosteroids and that was it. You would first do a puff of the bronchodilator and say they need another bronchodilator puff. You would wait 1 minute and then give the other one. So if you're giving the same medication, just 2 different doses, you're going to wait 1 minute. But if you were going to give a bronchodilator then a corticosteroid, you would wait 5 minutes, because we need 5 minutes for the bronchodilator to do its job. And then another thing you need to remember is that after the patient uses the inhaler after doing a corticosteroid, they need to rinse, they need to gargle and rinse their mouth with water and then spit that water out. Because the corticosteroid, whenever it comes into contact with those mucous membranes in the mouth, it can cause thrush. So it's very important you get your patient to do that. Next, what you want to do is you want to prime the inhaler. So you're going to prime the inhaler if it's the first time you're ever using it. If the patient hasn't used it in a week or more, has dropped it, or recently cleaned it. So before you do that, just make sure that your inhaler is in date, it's not expired. So to do that, what you're going to do is you're just going to gently pop this canister off, and it will tell you the expiration date. This is 2020, so we're in date. And the dose that we're using, this inhaler that we're using here, is a demo dose. It's a teaching dose. It does not contain medication. Also, never administer medications to a patient if you don't have proper credentials or if you've not been trained, and always follow your hospital protocols. So another thing, whenever you're going to go prime it, you want to check expiration date, but you also want to make sure that there's enough doses in this inhaler, because they only contain so many puffs. So a lot of inhalers have a counter on them, and it'll tell you how many's left, like 20, 10, however many. So look there to make sure you have enough. And if it doesn't say it, like this one doesn't, the box will tell you how many sprays are in each inhaler. And this one has 200 sprays. So you'll need to pay attention to how many sprays the patient's doing a day and calculate that out. For instance, say that the patient is doing 2 puffs twice a day. So how many puffs is that in a day? 4. And there's only 200 puffs in this box. How many days is this inhaler going to last if they do it every day? Just 50 days. So you want to keep track of that. Now, to prime the inhaler, what we're going to do is we're going to remove the cap and then just hold with your thumb at the bottom and your 2 fingers at the top and gently give it a shake. And depending on the manufacturer is how many sprays you're going to spray to prime it, because each inhaler is different. So always read the instructions. With this one, it's 4. So what we're going to do is just do 4 sprays. Now that our inhaler is primed, let me demonstrate for you the open mouth technique. I'm going to tell you about it and then I will show you how to do it. Okay, so what you're going to do is you're going to have your patient set up and you're going to have them hold the inhaler in between their thumb and their 2 fingers and give it a good shake for about 8 to 10 seconds just to mix up that medication really good. Then they're going to measure out 2 fingers width between their mouth and the inhaler, and make sure the inhaler is pointed at their mouth. And what they want to do is they want to breathe in and then breathe out through their mouth until they no longer can. And then after that, simultaneously, they want to hit the inhaler down and breathe in slowly through the mouth of the stuff that's coming out of the inhaler. And then they'll want to hold their breath for 10 to 12 seconds and breathe out slowly. If they need another puff of that same medication, they can do it in 1 minute. So let me show you how to do that. Then after that, recap the inhaler, and if it was a corticosteroid, be sure to gargle and rinse the mouth with water and spit, and perform hand hygiene and document. Now let me demonstrate the closed mouth technique. So what you want to do is hold the inhaler in between the thumb and the fingers and give it a good shake for about 8 to 10 seconds to get the medication mixed well. And you'll have the patient take a breath in and then out through their mouth until they can no longer exhale, and then put the mouthpiece of the inhaler in between the teeth, keeping the tongue flat and the lips sealed around it, and they will simultaneously hit the inhaler button and breathe in until they no longer can breathe in, and then hold it for about 10 seconds and then exhale slowly. And that'll look something like this. And after that, recap the inhaler. And again, if they were using a corticosteroid, have the patient gargle and rinse the mouth and spit with water, and perform hand hygiene and document. And if they needed to use the same medication again, when would they do it? They would do it in a minute. But if they were going to be using, say this was a bronchodilator and they needed to use the corticosteroid, how long would they wait? 5 minutes. Okay, so that wraps up this video on how to use a metered dose inhaler using the open and closed mouth technique. Thank you so much for watching, and don't forget to subscribe to our channel for more videos.